Conversing is produced and distributed in partnership with Comet Magazine and Fuller Seminary. I'm Mark Labberton. Welcome to Conversing. I'm very grateful today to welcome Shoshana Walter as our guest on Conversing. Shoshana is an investigative reporter for the Marshall Project, where she covers the criminal justice and child welfare systems. Her reporting has won dozens of awards, including the IRE Medal, the Livingston Award, the Knight Award for Public Service, and 2 Edward R. Murrow Awards. She's also been a finalist for the Pulitzer, the Emmy Awards, and the National Magazine Awards. Today, we're going to have the opportunity to talk about her first book. It's entitled Rehab, An American Scandal. Shoshana Walter, welcome to Conversing. I'm really delighted to have you as a guest today.
Thanks so much for having me, Mark. I'm so glad to be here.
You know, you've written this wonderful book that we're going to be discussing. It's called, again, Rehab, An American Scandal. And I think anyone that's been paying attention to the American landscape for the last 15 years, let's say, has been very aware that America has been in the grip of an opioid crisis, which is what the focus of the book is really about. And I'd love for you to start by just giving us a sense of how you were drawn to the topic and what early exploration led you to then decide to go all in and write a book about this particular crisis that's behind or beyond the opioid crisis, which is the rehab crisis. So just give us a little more of that background.
Absolutely. So, I'm an investigative reporter, and I primarily in my career have focused on the criminal justice system. And I remember when I first started my career, there was very little interest in covering addiction. And when stories seemed to relate to people who were addicted, there was often a doubt about people's credibility in participating in a story. And there was just a lot of pushback within newsrooms about covering addiction. And I saw that start to shift with the opioid epidemic, where there suddenly was more interest in covering addiction as a public health issue. And one of the reasons that is because the opioid epidemic, unlike, our previous major addiction crisis, which was crack cocaine, mainly affected white communities at first. It started out as a pain pill epidemic. Predominantly white patients had access to prescribed painkillers. And so the population of people that were affected by this drug crisis were predominantly white. And the country was starting to see more affluent people also affected by this crisis. And so, in a way that opened the door to more interest in coverage of this issue. And I remember, this is probably 9 years ago now, 10 years ago, an editor coming up to me at work, and she asked me to find an investigative story related to the court system, a very broad mandate. And so I started thinking about drug courts. These are types of diversion court programs that really gained popularity during the 90s and early 2000s that provide people, particularly people with drug problems, the opportunity to go to treatment instead of jail or prison. And most of the coverage of these types of courts was very positive, very glowing. I think in theory, these courts are a great opportunity to divert more people from our mass incarceration system. But I had also learned through all this new coverage of the opioid epidemic that we had a treatment shortage, that most people who needed treatment weren't able to get it. And so I was curious about where courts were sending people for treatment. And that's when I just sort of stumbled across this program that was being utilized by courts throughout Oklahoma and Missouri and Arkansas. And it had been founded, I learned, by a former poultry industry executive. And when I learned a little bit more about this program, I learned that it was predominantly, the main service it was providing to its court-ordered participants was labor. It was sending people to work without pay at for-profit chicken processing plants where they were manufacturing chicken products for KFC and Popeyes and Walmart and Rachel Ray Nutrish pet food brand. And they were working long hours in these grueling, unsafe positions. Many people were injured on the job and they weren't getting paid. And this was considered their treatment. And a lot of judges and attorneys were even aware that this is what was going on. And they were still sending people there. So it just kind of shocked me. I know investigative reporters are supposed to be jaded, but I'm still kind of shocked by it. And at that time, it really made me want to understand, if uncompensated labor, if indentured labor could be considered a form of addiction treatment in the U.S. today, then how common is that? What does the rest of our treatment landscape look like? And is it working the way that it should in order to actually help people recover from addiction? And that was kind of where I started with this book.
So they're living in a group home, but they spend all of their awake time, or a large portion of their awake time, working in these various contexts, like chicken products.
Correct. They were living in
labor.
Dormitories that one of the chicken companies, Simmons Foods, one of the big ones, had actually helped pay for. Yeah. And they were living and working there for years, sometimes longer.
Now, taking it at face value, I find it scandalizing, as you do, but just taking it at face value, what theoretically, besides the cynical observation that it was cheap labor, let's just go to the other side. What were they theoretically believing? That just being away from the context of drug taking and or the opportunity to do daily labor would itself be somehow corrective? Is that the theory of change that they were operating on?
I think so. Yeah. I mean, there were a number of things going on. One is that the program is called Christian Alcoholics and Addicts in Recovery, and it was a faith-based program. And anybody who was court-ordered there was required to attend church, was required to participate in these religious activities. And that, in combination with the work, was the majority of how they were spending their time. It didn't matter what faith you came to the program with. It didn't matter if, you weren't getting what you were supposed to get out of it. You were required to do it. And if you didn't work, if you didn't, participate in these activities, then you were sent back to where you came from. And because these were court-ordered, this was mainly a court-ordered program, that meant that they didn't comply with the requirements of the court and they were sent to prison or jail anyway. And
So that was the alternative.
That was the alternative. Even if you were injured, you had to keep working. If you couldn't, then you were sent back. And I think that the people who ran the program, I think they were true. Well, I honestly, I don't know their true motivations. One can never know someone's true motivations. But from what they shared with me at that time that I was working on this story, they really believed in the power of work to transform these individuals, that developing a strong work ethic would help these people overcome their addictions. And I think there's some aspect of that rings true in a way. I think that a lot of people come to addiction or go through their addictions and they lack access to education, to job training, to knowledge of how to function without this substance. And so a program that helps them achieve those things theoretically could be such a transformative, valuable program. But this particular program and many, many, many others like it have in a way become a source of unpaid labor, exploited labor. And that exploitation is not transformative.
Right.
Maybe
right.
it goes without saying, but
Yes. How many people, by your count, were involved in this network that you're just describing?
this particular program or
Yes.
the many others like it?
Just let's start with the one you were just referring to.
I mean, it's been a few years, so I don't remember the exact numbers, but I mean, there were hundreds who went through the program every single year, and it had been in operation for many years at that point. So we are talking about thousands of people who went through that program.
And if you broadened it to the other parallel programs, we're talking tens of thousands.
It's unclear how many of these types of programs exist because many of them are not licensed, they're not regulated. There's no one counting them or overseeing them or ensuring they adhere to standards of practice. So the precise number is unknowable, but the reporting that we did uncovered hundreds of these types of programs across the U.S. and a rough number, minimum number of people who go through this type of program every year. It's about 60,000 people who are required to perform uncompensated work. And I think the other thing about these programs, too, is that they are, in a way, serving a need because they are long-term programs. They provide people with a roof over their head. Theoretically, they provide some stability. They provide space for people to theoretically provide space for people to work on themselves. And we'll probably get into this because it's a big theme in my book. Most of the for-profit programs that are insurance funded operating in the U.S. today are short-term. Insurance companies don't want to pay for more than 30, 60 days in inpatient rehab. And that's definitely not enough time for many people to work on themselves and to gain what they need in order to sustain their recovery. And so these short-term programs kind of fuel relapse. And there's a real need for long-term programs, but insurance companies are not willing to pay for it. And many people are uninsured still in the United States. They don't have health insurance, and that's only getting worse. So in theory, long-term programs that allow people time and space to work on their addictions, to gain the skills and the resources they need to sustain their recovery, that is sorely needed. But unfortunately, that need is oftentimes exploited by people who are really interested in making a profit.
What kind of association is there between these programs and the Christian background? For example, is it just Christian individuals, or is it denominations, or is it organizations or institutions? What Christian expression lies behind this?
I would say most of the programs that I found like this were Christian-based and required, Bible study, required church attendance. And, what I learned in looking at how rehab is regulated across the country is that faith-based programs are oftentimes exempt from licensure requirements.
Because they're religious organizations.
Because they're religious organizations. So there's no oversight over these programs. They're operated however the operators wish to operate them. And because they are unlicensed, that also bars them from providing medical care, from providing access to prescription medications. So in this particular program that we've been talking about, there were people who were taking psychiatric medications because they had very serious mental health issues, and they were no longer allowed to take those medications in the program. So as a result of that, there was one man who had a psychotic break, and he ended up dying because he was cut off from these medications that he needed. So yeah, there's the way we're regulating rehab in this country, the opportunities we're giving people, it's really a dire situation.
And there are many unregulated groups that provide this kind of treatment besides Christian groups, right?
Yes, oftentimes programs that are solely 12-step based. There's no medical care, there's no access to medications. Those often can be exempt from licensure requirements. Sober living homes, group home situations are exempt from licensure requirements. And we've seen the for-profit insurance-funded rehab industry kind of taking advantage of that loophole. In California, there are a lot of for-profit treatment programs that are basically housing people in sober living homes and then sending them outside to their own treatment programs. And it means there are far fewer eyes making sure that programs are operating safely and with the best interests of their patients.
Mm. So, as I understand it from your book, there's sort of a convergence of a number of factors. There's the rise of opioids and the addiction issues, and the fact that it lies largely in a white population as opposed to crack, which was largely a Black population, but other people of color. And then you have this additional rise that every capitalistic engine in America wants to seize, which is the opportunity to provide services, some probably from positive and good intentions and some simply from opportunistic intentions. And then you have the Affordable Care Act, which suddenly provides funding to a vast number of people that would not have otherwise had any kind of coverage. And is it right for me to understand that the organizations, that little network you were just describing, what's paying for it is really the Affordable Care Act? Is that right? Or is that a misunderstanding?
I would say that most of these unregulated programs, the ones requiring unpaid labor, they are funding operations primarily through the unpaid labor. Now, that doesn't mean that they're not still profiting from the unpaid labor. I found many programs that were just drawing enormous profits, and one of those programs is featured in my book. But yeah, basically the premise of these rehab work camps, you could call them, is that the participants are paying for their own stay by working. And then the Affordable Care Act, it expanded coverage of addiction treatment to millions of Americans. And most of those rehab programs are funded by insurance companies.
I see. I see. Got it. So you're doing this research as an investigative journalist, and eventually you decide to focus on 4 people. These are the stories that you tell through the book, which are told in a really fascinating way, and you interlace their stories cyclically in a way as time passes and their own experiences continue to develop. Tell us how you came to those 4, besides the fact that you were obviously looking for a diverse and geographically distributed group of 4 people. Why and how those 4 people?
It was really, a process when I first began with this book of trying to understand what our treatment landscape as a whole looked like. And I started with interviewing experts on addiction and our treatment system. I read everything everything you could imagine about our addiction treatment system, other books, other news articles, academic studies. I just really wanted to get a sense of the whole. And then I used that information gathering process to narrow in on, the focus points of the book. One of the people in the book, Chris Kuhn, was someone I already knew through my reporting at the Center for Investigative Reporting at the time. And I knew from this larger reporting effort that one big theme in the book had to be our criminal justice system and how we still route so many people through the criminal justice system to addiction treatment. And many of those addiction treatment programs are very punishment-based. They're intent on breaking people down to their lowest point, theoretically to build them back up. But it ends up harming a lot of people. And Chris Kuhn was one of those people who was court-ordered into a program that forced him to work without pay for up to 80 hours per week. So I knew Chris was going to be a part of the book after he agreed to it, of course. And then the other themes kind of came about through this reporting process. There's a huge treatment gap in the United States, particularly for mothers, for low-income women. And I knew I wanted to kind of get at how our approach to addiction has changed over time from the crack cocaine epidemic to now. And so to find April Lee, I started interviewing groups that are focused on the child welfare system. April, at the time that I met her, was working at a law firm that specialized in representing parents with child welfare cases. And she had her own experience, with addiction that's detailed very vividly in the book. And her mother had been addicted to crack cocaine. She grew up her entire family had been affected by addiction in some way or another. And she personally witnessed our country's very punitive approach to the crack epidemic. And then she developed her own addiction and ended up losing her children because of it, couldn't get access to treatment. The only way she was able to access treatment was by getting herself arrested. So she was another person that I found who, helped me explore that aspect of the system. And then I also knew that addiction treatment medications like Suboxone, buprenorphine, methadone had to be a big part of the book because these, even today, they're still hard for people to access. And particularly during the early crucial years of the opioid epidemic, when greater access could have been so impactful, our country really did not make it as available as it could have. And that's when I stumbled across Dr. Larry Lay, who was one of the first Suboxone prescribers in the country, who ended up getting arrested by the Drug Enforcement Administration. And so his story kind of allowed me to explore that history and to show, how and why our authorities are still treating addiction treatment medications with suspicion. And then, Wendy McIntyre, the fourth person in this book, she's in LA or outside of LA now. She's been in the news locally for quite a number of years as an advocate for better oversight of addiction treatment. And so initially I interviewed her kind of as a subject matter expert to understand what the issues were with insurance-funded treatment. And in talking to her, I just knew, this is a committed, devoted person. She was a mom who lost her son to overdose in an unethical sober living home. And after that, she just committed herself to reforming this industry to such an extent that, she's been arrested. She's had treatment programs file restraining orders against her for her work trying to expose abuses. And she's just a very special person. And I knew that there was more of a personal story there that I could tell. And all of these individuals, a great deal of my reporting occurred during the early years of the COVID-19 pandemic. So initially, when I first sold the book, I thought I would be traveling across the country in person, doing a lot of on-the-ground reporting. I did eventually do that. But at the time that I was looking for these people, I couldn't travel. And I just had a baby. So it was crucial to find people who were in a good place to be able to share their stories, who could be partners in reporting out their stories and providing access to materials that I could use to tell their stories. And all four of these individuals were so generous with their time and with providing me the access that I needed.
Right. They're very moving stories, and they are different enough for the reasons you gave to really give us a whole series of windows into what feels like just a complicated morass of things internal to the people that are involved, and then definitely internal to systems and structures in the way that America's health service does and doesn't respond, and its judicial system does and doesn't respond. And the way that all this is being taken advantage of by various predator providers who are really, it seems, operating in a predatory way, even if they don't want to say that to themselves. the behavior suggests, as you clearly lay out, how predatory it can actually be, and therefore how much loss there is, even when supposedly the machine that they're operating is one that's supposed to bring about rehab. It feels like it couldn't be farther from the actual destination that people are being directed toward. I wonder if you could just take us into one of these stories, and in particular, if you would mind describing Chris's story even more fully, Chris Coons.
Yeah, absolutely. So Chris was 15 when he broke his ankle in a three-wheeler accident, kind of showing off in front of his cousin. He grew up in a suburb, in a kind of more rural area in Louisiana. And after he broke his ankle, he was prescribed prescription opioids. And that was kind of his first exposure to that medication that was so ubiquitous at the time. And it set off a period of adolescent experimentation with drugs and developed into an addiction in his early 20s. And Chris's parents were really desperate to help him. They sent him to a 30-day insurance-funded program, by all accounts, a good quality program. Chris finished it. He came home, and then he immediately relapsed, like a very common story with these 30-day programs. And then not long after that, he was arrested and court-ordered into this place called the Senecor Foundation in Baton Rouge, Louisiana. And Senecor operated similarly to the program that we were talking about earlier. Chris went in, he was told that he would be there for 2 years. He'd get counseling and medical care and group therapy. He would get to live and work there and save up money for after he left rehab. But soon after he arrived, he learned that the vast majority of his time would be spent working really grueling manual labor jobs up to 80 hours per week without pay. His only compensation was a pack of cigarettes per week. And he was working at laying rebar in the broiling Louisiana heat. He was building scaffolding at chemical plants. He was cleaning up after LSU football games. And this is basically how everyone in the program was operating. He barely had time for counseling. I spoke with Chris's counselor, who told me that, she would pop her head into his bedroom at the end of a long day, ask him how he was doing. He'd say, fine. And then she'd check that off as a counseling session.
Oh, my gosh.
So he really was, his sole form of what they were calling treatment was unpaid labor. And, unusually, Senecor was licensed. They were supposed to be providing medical care. Most people did not receive it, but they were supposed to be providing certain standards of care, and they weren't. And for years and years, regulators were aware of that and fined Senecor here and there, but failed to take any action. And that's, another thing that I found in my reporting is just how ineffective a lot of the regulations are over rehab programs. And so, yeah, Chris went through this program. I don't want to give his entire story away, but there were people within the program who were trying to help him, trying to make changes to the program, and it was allowed to continue operating.
Mm. Tell readers a bit for the full arc of his story.
So Chris, like a lot of people in the program, was badly injured on the job. When he complained that he needed more medical care, he was told to, he could either stay or go back to where he came from. And where he came from was court. So if he left, he risked being sentenced to 5 years in prison. So he stayed. And eventually he continued to work through his injury. And eventually he developed MRSA, which did lead to his ejection from the program. He was told that he'd be able to come back, but then when he went home to recover, he learned that he was not welcome back at Senecor. And so he went back before the judge thinking he was about to be sentenced to 5 years in state prison. And thankfully, the judge took pity on him and gave him probation. He left Senecor. He was feeling the lowest of the low. I mean, Senecor, it's not even depression that it gave Chris. It made him feel less than human. I remember him telling me a story about how some people on the job would call, rather than call him by his name, would call him Senecor. Hey, Senecor, come here. He felt deeply exploited and helpless, like he didn't have any control over his life, which is the exact opposite of the mentality that you need going into recovery. People need to have a sense of self-efficacy, that something that they do in their life will make a difference. And, when I first met Chris, I knew he really wanted me to write about Senecor. He wanted the injustice to be known, but he was also so hesitant to talk with me about it because it was such a traumatizing experience. And to rip off that Band-Aid again risks letting in all those feelings. So, the first time we met, I was working on a podcast with my colleagues. He agreed to meet with me on a break from a class at welding school that he was taking. And he came out with his, Diet Dr. Pepper from the vending machine and piled into the back seat of the car. He's a really big guy. So he was like kind of cramped in there with the microphone. And he started talking. And then once he started talking, he wanted to talk some more. And he eventually really opened up his life to me. And I spoke with his family and I also spoke with hundreds of people who went through Senecor with him to really get a picture of what this program was like. Collected internal financial records to see how much they were profiting from the program. And, and eventually, so back to the end of Chris's story, the judge took pity on him. Chris got probation, and then he was able to rely on the help of his parents to help him get back on his feet. He started going to welding school. He had another medical issue that he was prescribed prescription opioids for and found himself slipping. He told his parents, and his parents paid for him to get on Suboxone. And basically, Chris has remained on Suboxone ever since. He's now married. He has 2 stepkids. From what I understand, he's doing very well. So there can be happy endings, and I feel like there are some happy endings in this book, I promise.
Right. There really are.
Yeah.
And Chris's is certainly one of them. Thank you for sharing that story. I just think it's all part of the great good of this book, because what you're doing is laying before us both, in a way, the horror and nightmare and tragedy that's there, but you also do give us just enough of these signs of hope that it's evident that people can change, but the likelihood of that is going to be stacked by so many of these things that you have mentioned. Thank you for that story.
Exactly. Thank you, Mark.
I think one of the things that really moved me about all of the stories is of course, the full family systems that are affected by this, sometimes predisposing people perhaps to addiction, but also predisposing them to attitudes and assumptions about the world, about legal services, about medical services, that also just further complicate the whole picture, and the way that families, even when they're trying their very, very best, can often do so little to actually affect the change that they are aching for their loved one. I'm just curious, as you were doing this research, it must have been a very, very, very intense thing to be doing for you.
Yeah, I always usually say, it was intense for me, but also I'm not the person who had these experiences, right? So I have some remove from it, and I think that makes it easier to write about in some respects. And, I think also for me, reporting gives me a sense that I am doing something about an injustice that I see in the world. And that's a very empowering and motivating feeling. And I know that, these 4 individuals, and I spoke with hundreds of people for this book. I mean, there's so many people whose stories are not in this book, but they're reflected in what I was able to write about this system. And I think that it was a big motivation for a lot of people who talked to me. That, many of them had really horrible experiences in the system, but they wanted to talk to me because they want to see that change. And so I take that responsibility very seriously. And, I just hope that I did all of their words justice in writing this book, because what I want people to take away from it is that, our treatment system is not serving the people the way that it should, the way it was intended. And we could be helping people so much more than we actually are. And so many people spoke to me for this book with the hope that these words might have an impact.
Yes, right. Well, I think you do achieve what you're saying, and I found it very motivating and alerting to things that I think I knew but didn't know as thoroughly, or things that I supposed that I had wrong, or whatever it might have been. Very, very helpful book. I'm curious, when you sort of weigh the seriousness of where the crisis is, maybe we should start there. How would you describe the state of the opioid crisis right now?
Well, we're in an interesting moment because overdose deaths have gone down quite dramatically over the past couple of years. And there's many different theories for that. One is pretty grim, that a lot of people who were more vulnerable, more marginalized, overdosed or experienced complications from drug use and have passed away. There are some hopeful potential reasons for that. We saw an expansion of harm reduction practices, like distribution of overdose reversal drugs, and that's helped reverse a lot of overdoses. And then I think the other interesting reason that's coming out now is that the supply of fentanyl has dried up a little bit. And fentanyl was kind of like the third wave of the opioid crisis that proved especially deadly. And so we're seeing less fentanyl in the drug supply, which may be translating to fewer overdose deaths. But we're still seeing extremely high addiction rates. We're still seeing people living in really dire conditions, kind of stuck in the cycle of their addiction. And I think the thing that always gets lost in what we read about the crisis is that there are certain people who are more affected by it. And one population of people that is more affected by this crisis are mothers. Accidental overdose is the leading cause of death among pregnant and postpartum women. And since the opioid epidemic began, the number of programs that cater directly to mothers, directly to pregnant people, have declined drastically. So although we're seeing the number of overdose deaths drop, we're still seeing extremely high addiction rates, and we're still seeing certain populations experience very high overdose death rates. And one of those populations is mothers like April, mothers who, are struggling with their addictions, but they have children. They can't take time away from their children as the sole caregiver of their children to attend treatment. And so they're really stuck in this cycle of either losing their children to the foster care system or eventually overdosing and dying.
Mm. What are the statistics of overall opioid deaths in the last, whatever it would be, 10 years or 15 years? Do you know approximate numbers?
I mean, since the epidemic began, there have been more than 1 million people who have died in the United States from overdose.
Right. And of the demographic, if you take women in general, where are the other demographics, racially and or economically?
It's kind of shifted over time. Initially, proportionately, the vast number of deaths were of white individuals. A few years ago, that shifted, where the number of overdose deaths was disproportionately rising in Black and brown communities. And that's in part due to the fact that fentanyl was entering the supply of other types of drugs, fentanyl being mixed with crack or cocaine or meth. And so you saw a lot of low-income people of color dying, particularly in cities as a result of that. And now it's shifting again. And I think we're still collecting data and information about who is most impacted in this current wave of the epidemic. But yeah, we've seen some changes there over time.
So, Shoshana, if I was to anoint you queen of the forest, and you had total control to, quote, fix the crisis. Tell us what would be some of the key planks in your effort to do that.
I think a big one is this concept called recovery capital. I spoke with many, many researchers for this book who all emphasize the importance of recovery capital for long-term recovery. And recovery capital is this mixture of internal and external resources that people need in order to enter and sustain recovery. And that can include community, it can include transportation, housing, financial security, food, kind of all the basics that we all need in order to live healthy lives.
So a comprehensive approach.
Yes. What we're currently, someone who goes to a 30-day program and finishes it is much more likely to overdose and die in the year following treatment.
Yes, that was amazing to learn.
Than someone who didn't complete that program at all. And one of the reasons that is because many times people enter these programs, they become abstinent from the substance that they were using. They lose their tolerance, they leave, and they relapse. And because their tolerance level is so much lower, the amount that they took is enough to prove fatal. And, the relapses are happening because people are leaving these treatment programs without the resources that they need in order to actually sustain this change in their lives. Oftentimes, people are leaving these programs without those resources in place, without a plan to accumulate those resources. And so relapse in that instance is all but inevitable. And so I would say if there's one big change that could be made, it's finding a way to make the system more focused on that long-term process of change in helping people obtain what they need in order to actually sustain their recovery. That really what we have right now is kind of like a microcosm of our American culture, our ethos of pull yourself up by your bootstraps. If you just try hard enough, you work hard enough, you'll get there. But really, without that recovery capital, it's almost as much of an obstacle as the addiction itself. There's so many barriers to climb, so many obstacles to overcome in order to achieve that long-term recovery that oftentimes people are failing before they even get that opportunity.
So it's parallel really to prison recidivism, where if you have a network that helps you re-enter after you've been released, it's one story. And the absence of that story is much, much higher of recidivism.
That's right.
And it sounds like it's the same. It's parallel.
So yes, I think that's a very astute observation, Mark. Yeah. And people who recently released from prison also have some of the highest overdose death rates. So this is also in part due to the exact same reason.
Yeah. This is a funny memory, but at one time I was interviewing the mayor of Berkeley about something, and he was trying to explain all the social service programs that Berkeley has, which one can imagine and know are vast and complicated, all expressive of Berkeley's ethos. But he stepped back from it all for a minute and he said, you know what all this amounts to is that we've just decided everyone does better if they have a friend. Now, that was a quaint way of summarizing it, but it is a friend in this thick sense that you're describing, not just a friendly person, but a person who's actually going to be with you, or a community more likely, because it's so complicated and so many multi-layered elements to it. But we all do better if we actually have a system of support. And the absence of that system of support is in some ways both at the core of the crisis and certainly at the core of recovering from the crisis. But
yes,
that's a very hard thing for many people to be able to find and make and sustain.
Yes.
Really, really challenging. Shoshana, if you were to implement that plan and to try to think about how you would develop recovery capital, what are the critical elements within that you think are any ones that you'd want to particularly highlight?
Like which type of recovery capital is most essential?
Yes, exactly.
Gosh,
I'm sure it would vary, of course, because people's circumstances are different. So
yeah, I was just going to say, I think it really is so dependent on the individual. I could see, someone who's lacking any kind of job experience in the real world really benefiting from job training. Whereas there are others in their addictions who, they were, they did have careers or they did have jobs and they lost it all in the midst of their addiction. So they have that knowledge, but that's not necessarily what they would most benefit from. Maybe they would most benefit from community. And then, there are people like April, she really struggled in her addiction and it got worse and worse before she lost custody of her kids. Her children were taken by child welfare services. And, we know that programs that allow women to bring their children or that provide women with childcare have better outcomes for the entire family. And so in that instance, what would be most beneficial is to allow the family to remain together or to provide that parent with childcare so that they have time and space to obtain that treatment and then to be better suited to take care of their children. So it really is, I think, very dependent on the individual. And and also dependent on the individual is what are someone's motivations for getting better. I think that is kind of the part of the problem in our treatment system is it's a one-size-fits-all approach oftentimes. Like Chris Kuhn went into this program that required him to work without pay up to 80 hours per week in these manual labor jobs. Everyone was required to do it. No one was exempt. This was viewed as like, the way he was going to change. But, for someone like Chris, it was not effective. For a lot of people, that's not effective. You need to kind of meet people where they're at and figure out what is going to be their motivation for change and what are the services that they need in order to actually obtain that.
Mm-hmm. The U.S. has always been very slow at our willingness for various reasons to acknowledge crises and then to actually address the root causes as opposed to something that I would call more like a political position or a certain kind of moral vision of how the world should be. And then we try to correct toward that moral vision rather than toward the thing on the ground that's actually the crisis that a person's facing. So when methadone came out, there was a restraint on its distribution for reasons that I'm assuming are still part of the restraint on Suboxone's distribution and availability. Am I getting that right, or are these unrelated parallels?
No, that's absolutely correct. I would say there's still kind of a tight leash on methadone, especially, and also buprenorphine for sure.
Right. And what would release that? Again, back to being queen of the forest. If you could release that, what would you have to do to get that more fully distributed?
Well, I mean, I think that there are people working on this issue who have good answers.
I see. Which is what? What are the parts of the answers, I guess?
Yeah, I think there have been studies looking at mobile distribution programs that have shown them to be very effective. So, basically a van that drives around and makes methadone or buprenorphine available to people. There are doctors who set up on the street or go from homeless encampment to homeless encampment and make their services available. One of the things that I did when I was researching my book was shadow providers at the Bridge Clinic at Highland Hospital here in Oakland. And that program is a very low barrier to entry and remain program, meaning, you can walk in and see a doctor and they'll put you on a medication. And there were people who, were unhoused who were going to this program. I was amazed actually at the level of commitment some people had in going to this program to see doctors when they needed to. And I remember there was one individual I interviewed in his 60s, unhoused for many, many, many years. he would walk from the encampment where he was staying all the way to Highland Hospital. He would pick flowers from people's yards along the way. And then when he got there, he would present this bouquet to the receptionist. And, he'd been in his addiction for many years. And it's only when he turned 60, which was the age that his father had passed away from his addiction, that he realized he wanted to change. And so this clinic was helping him, was helping keep him alive, was giving him this medication that allowed him to abstain from the substance that he was using. And he still wasn't entirely sober. And, in many programs, when that happens, they kick people out. Oh, you did not comply with the rules of this program, you're gone. This clinic, they were allowed to stay because keeping them in care helped keep them alive and helped make that long-term change. And there were other people within the Bridge Clinic providing other services, peer navigators, a social worker to help people access resources they might need, a counselor so that people could get some counseling or therapy. So I think there are a lot of programs that are operating today that are doing really good work and seeing really great results from that work. And I would point people to those models. There are great models that are currently out there right now doing really great work for people.
Right.
And
Which is examples of recovery capital.
Yeah, exactly. Yes. And I think we could all use a perspective shift. I think what I hear again and again is, oh, this is so expensive. This will cost so much more money. But these insurance funded programs that put all these limits on level of care and time in care are in the end contributing to a massive healthcare costs, because people are going to these programs and they're relapsing and they're interacting with the criminal justice system, the child welfare system, the hospital system, our emergency room system. There's all these hidden costs that are a consequence of an addiction treatment system that's not serving people the way it should. So I think that there are ways that we're spending money that we could be changing. We could be spending money a little bit differently in order to make our system more effective.
So it sounds to me like while the addiction crisis continues, even though some numbers have dropped, depending on the population that we're specifically thinking about, that there has been some rise in improvement. And you've pointed to a number of these things. On balance, it's still a deficit, I think is what you're saying, even though there has been improvement. Is that right? Yes,
I would say so. I think, it's wonderful that harm reduction efforts have at least partially led to a reduction in overdose deaths. But what we're not acknowledging in that so often is the fact that people remain in their addictions. And the longer someone remains in their addiction, the more marginalized they become, the harder it is for them to get out of their addictions. And so I think we're still very much in a crisis, even if it's not leading to as many overdose deaths. And still, the number of overdose deaths is very high. It's a high number. But, just because people aren't dying doesn't mean they're not still suffering, doesn't mean their families and communities aren't still suffering as a result of that addiction.
And it doesn't mean that they have human dignity that needs to be acknowledged and served in whatever way is possible.
That's right. Yes.
Shoshana, thank you so much for this conversation. I've felt like this was a deep dive into a world that I'm certainly not in and day out, though I've had a lot of exposure to addiction issues and to treatment programs of different kinds. This just amplified my understanding greatly and gave me, I think, a still deeper understanding too of the personal and human journey that each of these people are on, and the significance of what it means in a morass of a problem and in a morass of systems that are succeeding and failing. It was really helpful to have 4 lives as entrapped as each of them are in their own particular ways, but also with signs of real hope in some instances, and the significance of their life having been really heard, reported on, dignified even by the care and thoughtfulness and kindness of your reporting. So thank you very, very much for the book, and thank you for this conversation.
Well, thank you, Mark. I so appreciate the kind words and the opportunity to talk about this.
Conversing is produced and distributed in partnership with Comment Magazine and Fuller Seminary. Peter Labberton is our engineer and editor. Evan Rosa is our producer. For more information about Comment Magazine, visit comment.org, where you can subscribe, read the current magazine issue, and browse their archive. Fuller Seminary is an evangelical, multi-denominational graduate institution committed to providing indispensable formational education for diverse Christian leaders everywhere. For information, visit fuller.edu. I'm your host, Mark Labberton. Thanks for listening with me.